The prevention of early-onset neonatal Group B streptococcal disease. Green Top Guideline number 36. Second edition, July 2012. Background. Group B Streptococcus or Streptococcus aeugulactae is recognized as the most frequent cause of severe early onset at less than 7 days of age infection in newborn infants. The incidence of early-onset neonatal Group B streptococcal disease in the UK, in the absence of systematic screening or widespread intrapartum antibiotic prophylaxis, or IAP, is 0.5 over 1,000 births. The UK National Screening Committee examined the issue of strategies for the prevention of early-onset neonatal Group B streptococcal disease in November 2008 and recommended that routine screening using bacteriological culture or near-patient testing techniques should not be introduced into UK practice. Antenatal screening. Should all pregnant women be offered bacteriological screening for Group B streptococcus? Routine bacteriological screening of all pregnant women for antenatal Group B streptococcus carriage is not recommended. If Group B streptococcus is detected incidentally earlier in the pregnancy, should women be treated before the onset of labor? Antenatal treatment with benzyl penicillin is not recommended. Antenatal prophylaxis with oral benzyl penicillin for vaginal or rectal colonization does not reduce the likelihood of Group B streptococcus colonization at the time of delivery, and so is not indicated in this situation. Intrapartum antibiotic prophylaxis should be offered to Group B streptococcus colonized women. Should women be screened for Group B streptococcus or receive intrapartum antibiotic prophylaxis if Group B streptococcus was detected in a previous pregnancy? Current evidence does not support screening for Group B streptococcus or the administration of intrapartum antibiotic prophylaxis to women in whom Group B streptococcus carriage was detected in a previous pregnancy. The time interval between the two pregnancies and the intensity of colonization in the previous pregnancy are predictive of recurrent Group B streptococcus colonization. Reducing the risk of neonatal Group B streptococcus disease in women known to be colonized with Group B streptococcus. How should Group B streptococcus bacteriuria in the current pregnancy be managed? Clinicians should offer intrapartum antibiotic prophylaxis to women with Group B Streptococcus bacteriuria identified during the current pregnancy. Group B Streptococcus bacteriuria is associated with a higher risk of chorioamnionitis and neonatal disease. These women should be offered intrapartum antibiotic prophylaxis. Women with GBS urinary tract infection or growth greater than 10 to the fifth power CFU per milliliter during pregnancy should receive appropriate treatment at the time of diagnosis as well as intrapartum antibiotic prophylaxis.
Should women receive intrapartum antibiotic prophylaxis if Group B Streptococcus is detected in the current pregnancy? Intrapartum antibiotic prophylaxis should be offered if Group B Streptococcus is detected on a vaginal swab in the current pregnancy. Vaginal swabs should not be taken during pregnancy unless there is a clinical indication to do so.
If Group B Streptococcus is present in a vaginal swab, it is likely that the risk of neonatal disease is increased. A risk of disease is 2.3 over 1,000 may be assumed.
How should women with known Group B Streptococcus colonization undergoing planned cesarean section be managed? Antibiotic prophylaxis specific for Group B Streptococcus is not required for women undergoing planned cesarean section in the absence of labor and with intact membranes.
Women undergoing planned cesarean delivery in the absence of labor or membrane rupture do not require antibiotic prophylaxis for Group B Streptococcus regardless of Group B Streptococcus colonization status. The risk of neonatal early-onset Group B Streptococcal disease is extremely low in this circumstance.
How should women known to be colonized with Group B Streptococcus who experience a spontaneous rupture of membranes at term be managed? Immediate induction of labor and intrapartum antibiotic prophylaxis should be offered to all women with pre-labor rupture of membranes at 37 plus weeks of gestation or more. If Group B Streptococcus colonization was identified earlier in the pregnancy by a swab taken for other reasons, immediate induction of labor and intrapartum antibiotic prophylaxis should be offered. How should women with Group B Streptococcus colonization and suspected chorioamnionitis be managed? If chorioamnionitis is suspected, broad-spectrum antibiotic therapy, including an agent active against Group B Streptococcus, should replace Group B Streptococcus-specific intrapartum antibiotic prophylaxis, and induction of labor should be considered. Chorioamnionitis is known to be associated with maternal and neonatal morbidity, including sepsis, neonatal lung and brain injury, and cerebral palsy. Management of labor, including rupture of membranes, to reduce the risk of neonatal Group B streptococcal disease in women without known Group B streptococcus colonization. Should women presenting in preterm labor with intact membranes be offered intrapartum antibiotic prophylaxis? Women presenting in established preterm labor with intact membranes with no other risk factors for Group B Streptococcus should not routinely be offered intrapartum antibiotic prophylaxis unless they are known to be colonized with Group B Streptococcus.
How should women with clinical risk factors such as pyrexia greater than 38 degrees Celsius in labor be managed? Intrapartum antibiotic prophylaxis should be offered to women who are pyrexial in labor, greater than 38 degrees Celsius.
Women who are pyrexial in labor should be offered broad-spectrum antibiotics, including an antibiotic for prevention of neonatal early-onset Group B streptococcal disease.
Intrapartum pyrexia greater than 38 degrees Celsius is associated with a risk of early-onset neonatal Group B streptococcal disease.
How should women with term pre-labor rupture of membranes be managed? The evidence for intrapartum antibiotic prophylaxis for women with term pre-labor rupture of membranes is unclear, and the National Institute for Health and Care Excellence recommends that it is not given unless there are other risk factors. Pre-labor rupture of membranes at term should be offered immediate induction of labor or induction after 24 hours. How should women with preterm pre-labor rupture of membranes be managed to reduce the risk of neonatal Group B streptococcal disease? Antibiotic prophylaxis for Group B streptococcus is unnecessary for women with preterm rupture of membranes. If these women are known to be colonized with Group B streptococcus, intrapartum antibiotic prophylaxis should be offered. Induction of labor should be considered if there is suspicion of chorioamnionitis. Should women with a previous baby with neonatal Group B streptococcal disease be offered intrapartum antibiotic prophylaxis? Intrapartum antibiotic prophylaxis should be offered to women with a previous baby with neonatal Group B streptococcal disease. Which antibiotics should be given to prevent early-onset neonatal Group B streptococcal disease? For women who have accepted intrapartum antibiotic prophylaxis, benzyl penicillin should be administered as soon as possible after the onset of labor and given regularly until delivery. Clindamycin should be administered to those women allergic to benzyl penicillin. It is recommended that 3 grams intravenous benzyl penicillin be given as soon as possible after the onset of labor and 1.5 grams 4 hourly until delivery. Clindamycin 900 milligrams should be given intravenously 8 hourly to those allergic to benzyl penicillin. There is a chance that clindamycin might be less effective. An alternative agent in this situation is vancomycin. Broad-spectrum antibiotics such as ampicillin should be avoided if possible, as concerns have been raised regarding increased rates of gram-negative neonatal sepsis. To optimize the efficacy of intrapartum antibiotic prophylaxis, the first dose should be given at least 2 hours prior to delivery. Benzylpenicillin levels in cord blood exceed the minimum inhibitory concentration for group B Streptococcus as early as 1 hour after maternal administration. Oral antibiotics for intrapartum antibiotic prophylaxis are not recommended because of variable absorption in labor. Should vaginal cleansing be performed in labor? There is no evidence that intrapartum vaginal cleansing will reduce the risk of neonatal group B streptococcal disease.
How should well infants at risk of early onset neonatal group B streptococcal disease be monitored? Well infants at risk of early onset neonatal group B streptococcal should be observed for the first 12 to 24 hours after birth with regular assessments of general well-being, feeding, heart rate, respiratory rate, and temperature. The great majority of infants, 89 to 94%, who develop early onset neonatal group B streptococcal infection develop signs within the first 24 hours after birth, and the majority of such infants, 65 to 67%, will have had one or more conventional risk factors.
A significant number will also have had signs of fetal distress, an emergency delivery, and low APGAR scores. Clearly, any baby with clinical signs and symptoms compatible with sepsis should be evaluated and commence on antibiotics. Other infants without clinical signs but with other risk factors should be observed closely for such signs over the first 24 hours after birth. Should postnatal antibiotic prophylaxis be given to low-risk term infants? Postnatal antibiotic prophylaxis is not recommended for asymptomatic term infants without known antenatal risk factors. Routine postnatal antibiotic prophylaxis is not recommended. How should the well infant with one or more risk factors be treated? Randomized controlled trials have not provided a sufficient evidence base for clear treatment recommendations in well newborn infants.
Around 90% of cases present clinically before 24 hours of age, so the risk of disease in infants who remain well without treatment beyond this time may not be substantially elevated above that of the infant with no risk factors. Prolonged observation of well infants is therefore not indicated.
However, in well infants whose mothers had risk factors and received appropriate intrapartum antibiotic prophylaxis, the risk of early-onset Group B streptococcal is significantly lower, and these infants can be observed for 24 hours without treatment. How should the neonate with clinical signs of early-onset Group B streptococcal disease be managed? Infants with clinical signs of early-onset Group B streptococcal should be treated promptly with appropriate antibiotics. Blood cultures should always be obtained before antibiotic treatment is commenced, and cerebrospinal fluid cultures should be considered unless the clinical condition precludes a lumbar puncture. A lumbar puncture should be obtained at the earliest opportunity once the clinical condition has stabilized. How should the infant of a mother with a previous infant with Group B streptococcal disease be managed? For a well infant whose mother has had a previous infant with Group B streptococcal disease, either clinical evaluation after birth and observation for around 24 hours are necessary, or blood cultures need to be obtained, and the infant treated with benzylpenicillin until the culture results are available. It is unclear whether further action is necessary for the well infant. Are routine neonatal surveillance cultures of value? It is not necessary to perform routine surface cultures or blood cultures on well infants.
Most infants who develop early-onset neonatal Group B streptococcal disease present with illness soon after birth, and 90% have presented clinically by 24 hours of age before culture results become available. It is therefore unnecessary to perform routine surface cultures or blood cultures on well infants, whether they receive intrapartum antibiotic prophylaxis or not.
Is there any need for breastfeeding to be avoided? There is no evidence to discourage breastfeeding when there are concerns regarding the possible risk of transmission of Group B streptococcal disease.